Now we will hear from Dr. Todd Davenport. He's going to be talking to us about a crash course in PENE. Dr. Todd Davenport will kindly share his expertise and knowledge on the pathophysiology on post exertional neuroimmune exhaustion, PENE, widely known as post exertional malaise. Health professionals can confidently engage in discussion with their patients or clients with better understanding and insights on PENE from this presentation. But because of the time difference, some valuable presentation will be pre-recorded because he's in America and it was going to be about 2 a.m. for him. So he's pre-recorded and shared his presentation with us.
Hello there. My name is Dr. Todd Davenport. Greetings from California. I am privileged to speak for the webinar event for the Myalgic Encephalomyelitis group of Australia, ME Awareness Day 2025. It's really a privilege to be able to do this because these patient advocacy groups like the ME Group of Australia are just doing wonderful work to raise awareness, visibility, and to advocate for um, improved education, research, and clinical practice as it relates to caring for people with ME. And so anytime I have the opportunity to support that, of course, I'm all in. So thank you again for inviting me to the webinar organizers. Thanks for joining. My talk's entitled Post Exertional Malaise, a shared primer for clinicians and patients. And you know, I was invited to give a talk that was directed more towards clinicians for about 20 minutes or so. So I'm going to try and hold myself to that. And I thought, clinicians obviously are important partners in clinical care, but I think also informed patients make for effective self-advocates and can really help clinicians sort of understand the reality of uh, day-to-day living with ME. So wanted to not cut patients out entirely of this equation because you all are so critical. So with that sort of in mind, I'll be presenting a lot of the information through the lens of a clinician with a lot of sort of detail and replete with lots of references to the peer-reviewed literature, but hopefully also patients who have tuned in may find something useful in this chat as well in order to help to um, advocate and direct their own care. So my employment, my relevant affiliations, I'm a professor and chair here at University of the Pacific, which is in Stockton, California, east of the San Francisco Bay Area. I also work with various different groups, Kaiser Permanente, um, Workwell Foundation as a volunteer research consultant, and I'm also the chair of Long COVID Physio. My disclosure is that I have no financial or non-financial conflicts related to this talk, and I'm speaking on behalf of myself. But my employers sometimes like to put my talks on social media when they're um, when they're um, when they're good. So a lot of what we know in this field relates to doing repeat testing, pre-testing, and then post-testing after a cardiopulmonary exercise challenge, usually a cardiopulmonary exercise test. And you see this in the form of a single CPET, where we have a pre-test and then one CPET and then a post-test. And then you see it also as in the form of 2-day CPET, where you have pre-testing, cardiopulmonary exercise testing in a first session, followed by a second test 24 hours later, and then post-testing. And this 2-day CPET was really originated by my colleagues at the Workwell Foundation, specifically Stacy Stevens, who's a patient living with ME herself, and an exercise physiologist really trying to understand the physiology underlying her day-to-day reality of living with post-exertional malaise. And so a lot of what we have, the literature that we have relates to post-exertional physiology, which is sort of a unique way to think about the biology of the system. And really, what we're getting at here is not so much the biology of how the body responds to stress, but also how the body recovers from stress, which is a key point. So we're looking at recovery responses. And again, the post-testing, whether this is in the form of a post-test variable or a second maximal CPET prior to the post-test measurements, all occur in the post-exertional state, which is really important, again, to understand the physiology of recovery. Probably the headline finding of repeat CPET testing or the Stevens protocol is that we've identified a reduction in the volume of oxygen consumed and workload in people with ME/CFS at submaximal exertion, suggesting that there's an early onset of anaerobic metabolism that occurs in the range of workloads and activity intensities that reflect activities of daily living. And so this might be partially responsible for the observation of a waxing and waning effect of the ability to do a certain activity at one intensity one day when that identical activity on a second day would be impossible. Again, what this suggests is this up and down type of window of metabolism for daily functioning, so that certain activities are possible or not possible, really kind of depending on this waxing and waning effect of the physiology. We see this also in terms of stratification by group. So VO2 and workload tend to decrease at peak exertion and at the ventilatory anaerobic threshold, which is submaximal exertion, based on how severe ME is. So mild patients tend to have higher VO2 peak and workload, and VO2 at ventilatory anaerobic threshold and workload than moderate and severe. So we see an interesting sort of stair step, type of a response here, where there's a significant decrease between the first test and the second test, and that there is a decrease in overall capacity in as the functional categories go from mild, moderate to severe. And just to give some context, even in people with mild impairment, they're at about 3.5 percentile compared to normal averages, population averages. And so you're looking at in a group of 100 people, people who are mild would have about 94 people standing in front of them in line in terms of their VO2 peak. By the time you get to moderate to severe, folks with ME/CFS are the last in line in 100 people. It just gives you an idea of how substantially impaired people are, even in so-called mild disease, which people might be able to sort of fake being well, but metabolically speaking, are really having a hard time. At submaximal exertion, we also notice that on an exercise test, people with ME/CFS tend to accumulate lactate faster and earlier in the test than matched controls who are sedentary. And we notice that this effect is more pronounced on the second test of the 2-day CPET than on the first test. So, we might say that the lactate accumulation curve shifts to the left in people with ME/CFS, whereas in matched control participants, we actually see a little bit later onset and less intensity of lactate on the second test versus this first test. So it's the opposite that occurs in controls versus people with ME/CFS. So that lactate accumulation curve shifts to the right, suggesting that deconditioned people become more efficient with either metabolizing lactate or maybe less accumulation of sort of concentrate, less generation of lactate, whereas people with ME/CFS actually get worse in terms of metabolizing or creating lactate during exercise. Just suggesting that, again, people with ME/CFS spend more time in anaerobic metabolism, um, suggesting in turn that there is aerobic system dysfunction. So the ability to metabolize fats and sugars in the presence of oxygen is impaired in people with ME/CFS, and even worse during recovery. This is some interesting work by Appelman and colleagues. This is people with long COVID. Many people with long COVID have an ME/CFS presentation. Not all, but many. And you'll notice in A and B there, oxidative phosphorylative capacity is less in people with ME, rather in long COVID, compared to uh, people who are deconditioned. These are healthy deconditioned controls. And after an exercise test is even worse, whereas not substantially changed in people um, who are deconditioned. And then succinate dehydrogenase, which you'll see in a few more slides, which is a specific substrate involved in anaerobic metabolism, is significantly reduced in people after an exercise test, in people with long COVID compared to healthy control. So this is occurring in the skeletal muscle, which is important because we use the skeletal muscle to be up and around. And we also see similar types of issues occurring in the blood, where we notice that certain substrates of anaerobic metabolism are impaired. So in the blood, um, which is here, we see pyruvate being decreased, and then we also see various different substrates being impaired, including succinate, which we just saw. And then over here on the muscle side, we see pyruvate being reduced, but certainly we see citric acid, alpha ketoglutarate, and then succinate also being impaired. So a whole host of different sort of substrates involved with aerobic metabolism may underlie the aerobic system impairment that we see in people with ME/CFS. Now, we didn't always think about post-exertional malaise as being relevant to identifying this subgroup of people with disabling fatigue among a constellation of different symptoms and signs. It wasn't until about 1994 with the Fukuda et al. Criteria where the PEM became optional. The first PEM required set of criteria were the Canadian consensus criteria, followed along 8 years later by the international consensus criteria in 2011. And since that time, all contemporary sets of clinical criteria for ME/CFS require the presence of post-exertional malaise. And this really seems to increase the specificity for the single coherent set set of activity intolerance, physiologically coherent set of activity intolerance, getting us away from like this global idiopathic chronic fatigue and more towards trying to characterize what we mean by ME or by ME/CFS. A whole host of unusual symptoms and signs persist after, in this case, exercise challenge in people with ME/CFS but not control. So on the top graph here, you see controls who basically just got off an exercise cycle. They of course they were tired. They had muscle and joint pain, headache, nausea, weakness, and instability, all very common after a CPET. But then 24 hours later, you'll notice very little of the symptoms, and by 1 week, again, no symptoms. But by contrast, people with, in this case, what we're calling chronic fatigue syndrome, defined by the Fukuda criteria, are very different. So fatigue, yes, but also 24 hours later and a week later. Here we have lightheadedness and vertigo, which we did not see in the controls. And then, again, we saw weakness, trembling, and instability present in a few people with controls, but a lot of people with chronic fatigue syndrome, and even 24 hours and a week later. We see some symptoms amplify. Muscle and joint pain, cognitive dysfunction, and headache all sort of started at a certain level and increased in frequency over time. And then we also saw insomnia, sore throat, swollen glands. And very unusual, did not see those in people who were deconditioned getting off of the cycle ergometer. Key differentiating factor here is within 24 hours, about 85% of sedentary control participants fully recovered compared to no one with ME/CFS. So impaired recovery is important. We also see fewer symptoms that improve more quickly in 2-day CPET. Um, in deconditioned individuals compared to more symptoms and slower recovery in people with ME/CFS. So again, that same observation that we see from one test persists in multiple tests. And as time goes on during recovery, it takes fewer and fewer reports of unusual symptoms necessary to differentiate between normal and impaired exercise recovery responses between people with ME/CFS and deconditioned controls. So what this suggests is that symptom reports by patients are credible. So how long does it take to trigger for PEM to trigger? In some people it's immediate, but most people it can vary. A plurality of folks, sort of say that it's anywhere from 3 to 24 hours later. And then PEM tends to last anywhere from 2 days to a week. But again, it can vary. And watch for folks that are more than a week because there are people who have exerted and have never recovered to their baseline. Just a really brief pathophysiology of ME/CFS. ME/CFS is associated with a whole host of different sort of subconditions involving inflammation, dysbiosis of the gut, autonomic dysfunction, endothelial damage. We talked about metabolic impairments, as well as autoimmunity and immune deficiency. And all of these, as we'll see in a few more slides, might be the basis for supportive care. Pyruvate dehydrogenase tends to be very important. This is a gatekeeping enzyme to mediate the conversion of pyruvate to acetyl-CoA, entering the citric acid cycle or tricarboxylic acid cycle, however you like. And this is reduced in people with ME/CFS. So again, maybe mediating the reduction in aerobic capacity that we see. We saw from a previous slide, oxidative phosphorylative capacity and succinate dehydrogenase activity was reduced in skeletal muscle in people with long COVID, perhaps arguing for an ME subtype. And that there are these abnormalities in oxidative phosphorylation and purine synthesis that occur after physical exertion in the muscle and also in the blood were observed. Been some additional blood metabolomics work in long COVID, again, kind of revealing a decrease in pyruvate and succinate content with blood metabolomics. And there's been some work done looking into the different subgroups of people with post-exertional malaise, really arguing for a couple of subgroups that are indicated by energy strain that is indicated by a decrease in lipid metabolism or an increase in fatty acid oxidation that's abnormal. And there's a subgroup that's similar to healthy controls. And so what that suggests is that there is a spectrum of disease that's happening where maybe early stage ME/CFS is difficult um, to identify based on the metabolomics, which wouldn't be a total surprise. We think that epigenetic modifications of the immune system, the autonomic nervous system, cardiovascular system, and cellular metabolism are at play in the development of ME/CFS through methylation, DNA methylation, microRNA in particular. And so the mitochondria are important not just because they're the powerhouses of the cell, but they may actually be the powerhouses of immunity. So we see a whole host of morphological changes occurring in mitochondria, as well as aberrant mitochondrial DNA, as well as signaling molecules from each of these substrates of the tricarboxylic acid cycle that crosstalk with immunity. So these bioenergetic impairments might not be only bioenergetic, but they also might be immune. Again, we can have a reverse in electron transport, which not only explains the bioenergetic deficits, but also might explain the potential mechanism for immune crosstalk as well. I do want to point out that post-exertional malaise is not a functional neurological disorder by its nature, because there is ample evidence of explanatory pathobiology. May not have the specific pathoetiology nailed down. That doesn't mean that we don't know enough about it to say that it is not itself a functional disorder. Um, ME/CFS and long COVID may be a combination of new onset or worsened pre-existing diagnosable health conditions. And we don't really see FND-like presentations commonly in these conditions, which is not to say that people with ME/CFS can't have an FND, but just to say that ME/CFS and post-exertional malaise are not functional, sort of by their very definition. And the importance of not misdiagnosing the patient really is paramount, because the interventions for FND might have a detrimental effect for people with ME/CFS. The international consensus criteria are here. In particular, I've highlighted the post-exertional neuroimmune exhaustion component, which is the compulsory condition, but also there should be neurological impairments, immune, gastrointestinal, and genitourinary impairments, as well as energy production and transportation impairments. And there's an entire checklist approach. And so the cornerstone of managing ME/CFS in the absence of an approved set of interventions is to identify and treat diagnosable conditions. And so under the umbrella of diagnosable conditions, you see several here that could be candidates for improving control and therefore improving quality of life in people with ME/CFS. But the first step really involves evaluating for post-exertional malaise, which is a two-step process according to the U.S. National Institutes of Health, initial screening, as well as confirmation. That initial screening is frequently done by the DePaul Symptom Questionnaire, Post-Exertional Malaise Subscale, which is sensitive and specific to demonstrate people with ME/CFS compared to healthy controls. In addition, there's some data out there suggesting that it can differentiate people with ME/CFS compared to multiple sclerosis. So there's really two steps to the questionnaire. There is the portion of step one, which is identifying at least moderate dysfunction at least half the time in at least a couple of those signs and symptoms, as well as answering step two, which involves the descriptor of the PEM symptoms. So it should be a frequency and severity score of any items 1 through 5 of 2 and 2. Need to have a affirmative response to indicate an ME/CFS diagnosis on item 7 or 8, as well as a response of at least 14 hours suggesting delayed recovery response for item 9. So we have the potential for false positives in this case. So it's really important to make sure we're screening using the supplemental items. So you have to use both parts of the questionnaire, and that exacerbation in particular with low-level activities with an impaired recovery response seem to be key differentiating factors of post-exertional malaise. All the step 2 items are highly sensitive that are most useful when you're ruling out, when those items are negative. So just ruling in, you have to sort of use caution that you're using your clinical sense, you're doing a thorough patient history, chart review, doing exclusionary testing, because having these items as affirmative may actually result in false positives. And, just fitting people to the case definition criteria, in this case, looking into using the Canadian consensus criteria in people with long COVID generally is very specific to select for post-exertional malaise, generally selects the cohort with greatest functional impairment and more impaired recovery responses and more frequent reports of worsening with physical and mental effort. So while the questionnaire is a really good place to start, we always go back to fitting to case definition criteria. And I would recommend the international consensus criteria that I presented earlier. So with that was sort of a very quick bite of information. Hopefully you found helpful. Certainly, if you have questions, additional conversation, I invite you to connect. My email address is on the screen. I am still on Twitter and I am intermittently also on Blue Sky. But again, thank you so much for the opportunity to speak with you today.